So I'm here with Dr. Carolyn Best, a urogynecologist, and we are here to talk about pelvic health.
Yeah.
So thank you so much for doing this.
No problem.
And you're going to share so much important information to so many women. So thank you.
Sure, happy to do it.
Okay, so let's talk about that. You're a urogynecologist. That's a mouthful. That's a pretty specialized field in medicine. Can you tell us what you do?
So I am a gynecologist. So I did my training in obstetrics and gynecology. So I'm an obstetrician as well as a gynecologist. But I did a couple more years of training after that to specialize in helping women with pelvic health, pelvic floor disorders. So that is predominantly urinary incontinence and pelvic organ prolapse. So I spend all my time talking to women, diagnosing the problems, explaining to them and teaching them about what's happening to their body, and also treating those issues. And so I'm also a surgeon because a lot of those conditions are treated surgically.
Okay, so that's a lot.
It is.
High achiever.
No!
Just teasing. Okay, so you reached out to me originally over Instagram, which I still think is really, really pretty cool.
Yeah.
And it was, if I recall correctly, it was a post where I actually had this chicken and I was talking about prolapse.
Yes.
And I was doing this and I was saying, guys, make sure you're breathing properly and you're exercising correctly.
Yes.
And you reached out to me and I was like, oh my goodness, I've got this, urogynecologist reaching out to me. Can you tell me why you reached out?
So I think we did have some mutual friends on Instagram. I participate in social media and I like Instagram, but I'm also interested in fitness and I do yoga and I like Pilates and those things. So I was following you for a while and I saw that you started to talk about pelvic health and how you were passionate about this as well. And so I was listening more. And I think the clincher was that chicken post. So I saw the visual of what can happen when you suck your abdominal wall in and the organs come down. And when I saw that and I saw the response that you got to that post and how many women made comments, had questions, and how many followers you have, I thought, wow, maybe we can work on this together. Because I find in my daily practice, I'm meant to be the person at the end of the line to really deal with fixing severe or significant problems when other things haven't worked. But I find it's dramatic to me how many women don't even have any awareness of their body and what's happening, or also just any knowledge at all. And I really feel like that is an area where we can work to improve things for women in terms of getting the message out there. Yeah. So I think that's why I messaged you when I saw that chicken. I thought maybe I can work with this girl.
I love it. We're on the same page. We need to spread the word. I mean, women can really do a lot of things preventatively to some extent, right? And so that's kind of the idea.
Absolutely.
So what do you wish more women knew about their pelvic health in general?
Oh, so many things. But I'm biased because this is what I talk about every day, all day long. But really, I want women to know that this is not a part of their body that they can ignore. And we would love to do that. And I'm not trying to add to the list of health concerns that we pay attention to. I think that when we look after ourselves genuinely about our health, we also can help that part of the body. But the point is that, like any other muscle in the body, our pelvic floor needs to be exercised and maintained. And I wish that women knew that, and also that they're not alone when they develop a problem. Lots of women feel shame and embarrassment and, think, why am I the only person that this is happening to? But believe me, if you come to my office and see the waiting room, you are not the only person. So I want them to know that. And I really just want them to know all the things that they can do to potentially prevent themselves from having to see someone like me.
You're amazing. Girl crush. But anyways, no, you are. You're amazing. Okay. And this is such a really important conversation. And it heartens me to know that you have the same goal that we all do. For sure.
Yeah.
Okay, so this is a big question.
Yes.
Bladder surgery.
Okay.
So when is it absolutely necessary?
So my students and the residents that I work with, because I do a lot of teaching as well, and my patients all will say that I am a broken record. I say the same thing over and over again. And that has to do with my narrow scope of practice. I only sort of deal with a few things. I'm very focused. But what I say all the time is that This is elective surgery, meaning that it's a choice for a problem that is affecting your quality of life. It's not a life-saving surgery. It's not like a cancer surgery or a breast cancer surgery. These issues, although they can dramatically affect your quality of life, they are that. And so the surgery is a choice. I would actually go so far to say that incontinence or bladder surgery is never completely necessary. It's a choice. And so I try to help my patients to understand their risks and their options. And really they make that choice. But it's necessary, or we choose to do it, to answer your question, when we feel, or when a woman feels that the problem is really affecting their everyday life. And those are the times where the potential risks, which many times are low, are worth taking on because of the improvement and of their quality of life that they are likely to gain.
Yeah, no, that's a really good answer. So when it's just become too hot on a daily basis.
Yeah, exactly.
Okay. No, that's a good one to know. So outside of surgery, what are some less invasive ways that women can manage their symptoms or help with their prolapse or incontinence?
So that's a great question. There's lots of things that women can do. And what I would like to see, again, back to your previous question, is people knowing more about this before they get to a specialist. And so I do a lot of talks for other healthcare professionals about it, and I'm trying to involve a lot of them in getting the word out and learning how to help women as well. But what prolapse and incontinence are different things. I don't think everybody knows that, at least when they don't know that when they come to see me. But prolapse is when the pelvic floor supports are lessened or diminished, allowing gravity to have an effect, often again after having vaginal births, where the organs, whether it's the walls of the vagina or the uterus itself, are now coming out and falling out of the vagina. So it's a sense of pressure, almost like a hernia by way of the vagina. So that's what prolapse is. Prolapse doesn't necessarily cause urinary incontinence. Incontinence is its own thing.
That's a big point.
Yeah.
That a lot of
people don't know that.
Yeah, I don't even think
well, at least I'm not having incontinence. Well, they're separate.
Yeah.
And you can have them together because certain types of incontinence are also an issue of loss of support. But you can also have them completely independently. So incontinence, there's different types of incontinence. Some types of incontinence are treated mostly with lifestyle changes or even medications. The only kind of incontinence that's treated surgically is called stress incontinence. So if we're talking about stress incontinence, which is a support issue, and prolapse, I always talk to people about their lifestyle. Some women find that losing weight helps their symptoms because of the effect of gravity and the pressure on our pelvic floor. We also talk about avoiding constipation, because constipation can worsen the symptoms but also make the prolapse worse over time, or the effect on their pelvic floor. So those are some of the lifestyle things. Also what they're drinking and when they're drinking it when it comes to incontinence, specifically caffeinated beverages. Make it worse for certain types of incontinence. So we talk about that. But then pelvic physiotherapy is huge, actually, I think. And I work with a lot of physiotherapists. I send a lot of my patients to the physiotherapists, especially before the condition becomes severe, because it's not just about doing your Kegels.
No. You guys have heard that before. It's
about strengthening and pelvic floor muscle training to strengthen the supports that we have. So that works for stress incontinence and prolapse. So I make sure I tell everybody about that. For prolapse, to a certain degree, when incontinence is severe enough, I'm realistic and I say to people, that isn't going to necessarily take it away, but it can improve it for sure. So it's worthwhile. And then another thing that isn't surgery or that isn't invasive that I talk to women about are things called pessaries. So pessaries, or support devices that are worn in the vagina, can create support to the walls of the vagina or the urethra, where we pee out of, the tube that we pee out of, the pipe, to help create support to stop the leaking. Or with pessaries, also they create support to help the walls of the vagina be more supported.
And there's different shapes and sizes.
There's different shapes and sizes of pessaries that help with these problems. We tends to be, not custom, of course, but tailored to the person in terms of fitting pessaries. But those are all things that aren't surgery that we talk about a lot and that we do a lot.
Okay, that's great. Thank you for that.
No problem.
That's really helpful to know. Okay, so can you tell us, back to surgery, can you tell us a little bit more about the surgeries that you perform on a very frequent basis?
So again, the types of conditions that I do surgery on are stress incontinence. So that's
sneeze leaks.
Yeah, the loss of urine that you don't want, with a laugh or a cough or a sneeze or a jump or a jumping jack or going for a jog or jumping on a trampoline, which is hard for lots of people.
Yep.
So that's stress incontinence. And then prolapse, again, with things falling down. I do surgery on those things.
Okay.
And that's really all I do surgery on.
Still a lot.
Still a lot. But that's what you're going to find me in the operating room doing.
Okay.
So there's many different things that I do in combination. Some women are having surgery for both. Some women are having surgery for just one or the other. Again, when we've gone through that decision-making process and when other things have not worked. I do a lot of prolapse surgery on repairing the walls of the vagina back in. So we're repairing the walls back in. Either a cystocele, which is the front wall coming down, or a rectocele, which is the back wall coming down. Sometimes women suffer from uterine prolapse, so we do sometimes do a hysterectomy. We will even do the hysterectomy vaginally, where we remove the uterus that way, or laparoscopically, to allow us to suspend the vagina back into their body, usually using their own ligaments, but sometimes not. Sometimes we do use mesh in the suspension of a vaginal vault back into the body, and so that's a more detailed conversation.
Yes.
But that is something that I do, and I do it a lot laparoscopically with small incisions. People call it keyhole surgery or minimally invasive surgery. Incontinence can be surgically treated, stress incontinence, in a number of ways. We traditionally, in the past, and still to this day, do a surgery through an open incision, almost like a C-section incision above the hairline, where we go down and put a stitch on either side of the bladder neck to pull it up. It's called a birch, and we still do that, but it is more invasive, so we don't do it as much as we used to. But it works well. We can also do that surgery laparoscopically, again with the small incisions. There is a surgery or procedure, I guess, where some of us will perform called a bulking agent, where we inject a material into the urethra to help bulk it up, to be a little bit tighter, to help the leakage that way.
Okay.
And then finally, to be honest, what I do for stress incontinence still most often is we still do a group of surgeries called a midurethral sling, and it is a mesh sling that we put through the vagina to create support where that support has been lost of the urethra, where we pee out of, which is it's that loss of support that causes the leaking or allows it to happen.
Okay.
Yeah.
There's so much to discuss here.
So much to talk about.
Another video.
This is what I tell people when they ask me.
There's a lot of information, right? So just I think what I'm taking away is that the surgery that you do for prolapse is a whole different scenario than a surgery that you would do for incontinence. They're separate. Yeah,
and not to get too technical or specific, but you know, the point is I do have to explain things to people, and I usually draw pictures, actually, because it's the best way to describe it.
Okay.
But prolapse is its own thing in terms of how we approach that surgically, compared to stress incontinence, which is its own thing.
But you can sometimes do them at the same time.
Surgically very differently, but sometimes, very often, we're doing them at the same time because women have more than one thing happening.
Got it. Okay. Thank you so much. Okay. So we're almost going to wrap up, but I think this is a big question that really gets me. So what is it that you would like to see change in the world of women's pelvic health as a urogynecologist who sees sort of women at the end stage when they've exhausted all of their options and you're cleaning up a lot of messes, so to speak?
I think that, there are large wait lists to be seen for some of us for these conditions, and really that's because there's not many of us that dedicate our time to this, and they're very common problems. I want women to know that it's not normal. Normal implies you live with it, and you don't have to, but the conditions are extremely common, so that's why sometimes there's a long wait. So in terms of what I'd like to see change, I think the most important thing is for women to talk about it. Because I have a lot of patients that are, again, afraid or shameful to discuss it even with their doctor. And I think that the more we talk about it, the more we create an environment where it is safe to say, I have this problem, and also improve, therefore, the quality of the information that we have out there. All of us go on the internet. We look for answers, and we look for information. Perhaps on our own in front of a computer screen, because that's easier, more private, and safer than talking to other people about it. And the information on the internet is not necessarily all of high quality or all thorough, and some of it is frankly scary. So I think what I'd like to see change is us have an environment where we feel comfortable and safe talking about it more, so that we can improve the information that's out there and keep people informed, so that they know what their options are before they see someone like me. But also, the more we talk about it, the more we can change our system and improve access for all of us, really.
Yeah, I would agree with that.
Yeah.
Well, I'm really happy you reached out, and I feel like this is the beginning potentially of something really exciting, and I'm grateful. I'm grateful for physicians like you who are interested in collaborating and kind of getting this word out there to essentially everyday regular people on a large level, which is really powerful. I
think I also want women to know that we're not just interested in doing surgery all the time. I want to help them to be aware of their options before it gets to that point. I think there's so much to do about prevention.
Good. I'm really grateful for you. Thank you.
You're welcome.
Dr. Carolyn Best. She is available at her Instagram feed. What is it again? You're an amazing chef. Remind me.
Best budding chef.
Best budding chef, yes. And also practices here in Oakville, Ontario. And we'll be hearing more from Dr. Carolyn later on, perhaps with some more videos discussing sort of more of the details of these huge topics. So thank you again.
Huge, yeah. No problem. Thank you.